I would like to thank Dr. Srinivasan for making me a part of this course, and the topic of my presentation is lamellar grafts and managing suppurative keratitis. I do not have any financial or proprietary disclosures in the products mentioned in the presentation. The concept of lamellar grafts in suppurative keratitis actually emanated possibly from the concept of component surgery of the cornea and optical graft. And just like anterior lamellar keratoplasty and posterior lamellar keratoplasty is done for optical purposes, likewise therapeutic deep anterior lamellar keratoplasty in selected cases is now being done instead of therapeutic penetrating keratoplasty, mainly because we have moved from an era of overkill therapeutics to an era of a more customized approach where component surgery of the cornea is done. The advantages of the lamellar grafts are well known to us. There are less chances of rejection and graft failure. The recipient endothelium is preserved. Less chances of intraocular complications such as cataract, secondary glaucoma, and endophthalmitis. And donor quality criteria are less stringent. The disadvantages are that there could be recurrence of infection, there could be intralamellar vascularization, there could be microscopic foci which we may miss on our clinical judgment, by our clinical judgment, or when we excise the tissue. The optical clarity may be compromised due to interface, and it is technically quite difficult and challenging. The indications are active and progressive microbial keratitis, non-responsive to maximal medical therapy, and the infection is not yet progressed to endothelium and in cases of descemetoceles. It has been undertaken for bacterial, acanthamoeba, and microsporidal keratitis, and I have written fungus in the end because I do believe that fungus tends to penetrate deeply, and it is virtually almost impossible to clinically assess whether the fungal organism is completely eradicated or not. The contraindications are perforation, large ulcer with excessive thinning, limbal or scleral extension, and of course if the surgeon is not confident of doing it. Preoperative evaluation consists of slit lamp biomicroscopy to know, very importantly, the depth of the ulcer, associated thinning and perforation, and the anterior chamber depth. And it is important to do the microbiologic workup, and if available, an anterior segment OCT can be done to know where to know the depth of the ulcer. Much of what I would be talking about has been already available on the net in the Current Opinions of Ophthalmology, a review article that we published, and Survey of Ophthalmology, again another review article that we published, which came last month. Essentially, the preoperative treatment consists of appropriate systemic and topical antimicrobials, avoid use of topical and systemic steroids, and intravenous mannitol may be given to decrease the positive vitreous pressure. We prefer to do it under general anesthesia. Peribulbar anesthesia may jeopardize the integrity of the globe, ensure hypotony, akinesia, and anesthesia, and exposure should be done preferably with the lid sutures or a self-retaining speculum. The donor tissue considerations are that the suboptimal grade tissue can be used. It has also been done by glycerine preserved eyes. However, good grade tissue should always be available in the event of a perforation. It has been done by various techniques, including the Unver's big bubble technique, manual layer by layer lamellar dissection, and viscoelastic assisted deep anterior lamellar keratoplasty in descemetoceles. When there is central involvement with a fairly normal periphery and deep stromal extension, a big bubble technique can be used. But the big bubble should not be injected with great force because these layers are already edematous, and a big bubble may cause rupture of the descemetous membrane if a great amount of force is used. Manual is more predictable, and even if it is an extensive infection which reaches the descemetous membrane or involves the limbus periphery, manual technique gives you a better control. So this was a case of a descemetocele with the focus of infection. You see there the size of the graft. Sometimes you have to take eccentric graft depending upon the area of the infiltrate or the descemetocele. Just a mark is given with the trifine. Important thing to note is that we do not do any triffination, and physiological rather than pathological separation of the descemetous membrane is already there with the overlying stromal layers, and so what is first done is the debulking of the anterior stromal layers, which then helps you to reach up to the descemetous the mark is okay. We have described the surgical technique of deep anterior lamellar keratoplasty in descemetoceles, and we did it in 12 eyes. Again, this is the schematic diagram to show the same. Okay, again, you mark the area which has to be trepanated, and this is just to assess the size of the trephine that would be used in this case. AC paracentesis done so that the descemet membrane, it actually falls back, and after doing this, a trephine is then taken, and one can use Genesian violet to mark the area of trephination, and viscoelastic is then injected from the wall of the base of the descemetocele into the underlying layers. And again, like I was saying earlier, because the pathological stroma is already hydrated, the descemet's membrane, it is easy to separate this kind of descemet's membrane from the overlying stromal layers, which is not so in a case when you do it for optical reasons. And after marking this area, the corneal debulking of the layers is done. So layer by layer, you remove the anterior stromal layers so that you have less tissue which is remaining underneath. And when the clear descemet's membrane is left behind, then you suture a full thickness donor cornea. And this ring around the descemetocele, some tissue may be left behind, and again you are putting the viscoelastic to cause the separation. And then Varna scissors is being used to actually cut the overlying stromal layers with the help of divide and conquer technique. And as you cut the layers, it is imperative to inject some amount of viscoelastic underneath. And this bears the descemet's membrane, and this is followed by suturing of the full thickness donor cornea, from wherein the descemet's membrane has been removed before, and interrupted sutures are then applied. Presentation. Okay, so post-operative regime consists of topical antibiotics and systemic broad-spectrum antibiotics, topical steroids, cycloplegics, and anti-glaucoma medications. For fungal keratitis, we do not start topical steroids immediately, but after epithelialization occurs probably after 2 weeks, along with cycloplegics and anti-glaucoma medications if required, and systemic antifungals are given. Important thing to note is that these grafts tend to be a little more edematous as compared to the optical deep anterior lamellar grafts, but over a period of time they do clear. The complications are recurrence. This is a case where of infectious crystalline keratopathy, where deep anterior lamellar keratoplasty was done. The recurrence occurred in the graft. So first therapeutic PK was done. Again the recurrence occurred in the graft. Second therapeutic PK was done, and again from the graft host junction there was thinning and corneal perforation. So a third penetrating keratoplasty was done, and when the third graft was being done, the lens actually popped out during that surgery. So the patient had undergone LASIK, and now finally is aphakic with secondary glaucoma and a visual acuity of 618. You can have problems of double anterior chamber. If they are shallow, they generally subside on their own, or you may have to inject C3F8 gas injection in cases where descemet's membrane detachment is large. There may be descemet membrane folds which over a period of time do disappear. And suture removal in a case of DLK, you have to treat the wound like a penetrating keratoplasty, because only the descemet membrane is remaining behind, and if you are too overzealous to remove the sutures, this may cause risk of wound dehiscence. This is one of our cases where we removed the sutures early and we had to resuture the graft. There can be graft rejection. In this case occurred because of suture infiltrate which incited the rejection, but it got resolved on topical therapy. The only study which is available in literature which compares therapeutic DLK with therapeutic PK is one which is published by Dr. Donald Tan's group, and cases of therapeutic DLK had success rate of 84% versus PK who had success rate of 88%. Recurrence of infection in the therapeutic PK group was seen in 12 eyes, out of which 6 had endophthalmitis. Vis-a-vis DLK, which did not happen there. And this is the results wherein we did deep anterior lamellar keratoplasty in descemetoceles, and except for 2 cases, the results were good. To conclude, I would like to say that lamellar grafts are indicated only in selected cases. They do obviate the problems of full thickness graft, but a backup good quality donor material is required. They are technically more difficult to perform, and meticulous follow-up is mandatory. And we do need randomized controlled prospective studies to compare therapeutic DLK and PKP to establish their conclusive role. Thank you for your attention.